Welcome to Academy of Ultrasound. This lesson is dealing with Echo233, week 6, and we're going to be talking about Essentials of Echocardiography, Chapter 9, and dealing with pacemaker optimization. I'm John Sheldon, one of the Academy instructors, and I'll be leading your course today. As you can notice from my screen, on the left-hand side, we have Chapter 9 from the Essentials book open. And on the right-hand side, we have the student notes that are available to you on Moodle. So when we're talking about pacemaker optimization, you need to be aware that when somebody puts in a pacemaker, for whatever reason that pacemaker is in, it's not necessarily perfect out of the box. And therefore, we use a process called pacemaker optimization to deal with the individual patient, to give them the same pacemaker that several people may have with different settings, can control different people's hearts in a different format, and therefore give them the best output. So just like the heart is like a car engine, each chamber of the heart would be considered the cylinders. And if you have an electrical disease, it causes problem with the timing and the activation. So if you do not get the electrical stimulation transferring across the heart as it normally should, then you have problems with the timing, and therefore that's why we're putting in a pacemaker. Engine doesn't run properly if the timing is not just right. So the goal of putting in a pacemaker and optimizing it is to restore normal electrical and mechanical function of the heart. We first started using pacing back in the mid-1950s, and that's something that you will see on your registry is when does pacing typically start, and it was in the mid-1950s. At that time, we only used a single pacemaking chamber or a single pacemaking lead, and it controlled the right ventricle. By realizing that this was very, very crude, obviously they wanted to get better and better and able to control the heart. They ended up coming up with several formats. So the way the heart normally works, this particular right chamber pacing was able to provide the patient with a normal heart rate. They weren't able to restore the normal atrial and ventricular contraction sequence, which is referred to as AV synchrony. This was becoming something that very quickly led to realize that even though we could give them a normal heart rate, we could not force the heart or keep the heart into a normal atrial and ventricular contraction. So if you look on the left-hand side, you'll see a lot of things that deal with single chamber pacing problems when you're pacing from just the RV. By using just the RV, you have no idea when the right and left atrium are contracting because you're only pacing the right ventricle. So you don't know if the atrium are contracting or when they're contracting. So sometimes you have a late contraction of the right and left ventricle in relation to the left and right atria. If the ventricles contract too early, atrial contraction can occur at the same time as ventricular contraction, and the atrial contribution to RV and LV filling will go backwards instead of forwards. The atria are contracting against a closed or closing AV valve, a mitral or tricuspid valve. Heart failure patients, because they typically depend on left atrial contraction to provide approximately 50% or more of the LV filling, this becomes a big issue. If the ventricles contract too late, there's a long pause between the end of atrial contraction and the onset of ventricular contraction. This results in a delay of the early filling phase and fusion of early filling and atrial contraction, which causes diastolic regurgitation across those AV valves, tricuspid and mitral. So what the next step in the evolution was, is they developed what was referred to as dual chamber pacing. Dual chamber pacing, by going into the RA, or right atrial appendage, and the RV, you're able to ensure that ventricular contraction starts at the end of atrial contraction. So let's move on down into the page, or onto another page. So typically what was ended up happening is that you develop a left bundle branch block. RB pacing will typically cause delayed activation of the posterior and lateral aspects of the left ventricle, and also give you paradoxical, which is out of normal, septal motion of the interventricular septum. This late activation causes a reduction in stroke volume and promotes left ventricular remodeling in heart failure patients. So in 1990, and you need to be aware of this, we developed, or was developed in the late 1990s at the Iowa Heart Center, they developed a biventricular pacing device. A third lead is introduced into the coronary sinus, where it is advanced alongside the left ventricle. The left ventricle then can be activated slightly before the right ventricle. This pre-excitation of the left ventricle allows left ventricular contraction to catch up with right ventricular contraction, thereby giving the heart, again, promoting synchrony. If this dyssynchrony that's been developed in the heart is reduced or eliminated, the left ventricle will start to reverse remodel, where it changes shape and size, and the patient's heart failure symptoms can subside. This therapy is referred to as CRT, or cardiac resynchronization therapy. You will be aware, or need to be aware, of the term CRT, and it stands for cardiac resynchronization therapy. If the patient's problems don't have anything to do with dyssynchrony, then obviously they're not going to respond to CRT therapy. Also, I do want to make sure that you're fully aware that that third lead is introduced into the coronary sinus and goes into a posterior lateral position alongside of the left ventricle. It does not go into the chamber itself. It goes through the coronary sinus. And the job of the third lead is to allow left ventricular contraction to catch up with right ventricular contraction, and it is referred to as CRT. So some of the things that need to be dealt with now is, if you could identify that a patient was having dyssynchrony, you'd get a lot of help towards deciding whether or not they would benefit from CRT therapy. The methods that we're using right now include M-mode, Doppler tissue imaging, quantitative tissue Doppler, tissue synchronous imaging, 3D volumes, velocity vector imaging. There's lots of things in right now that are in the process of being looked at to try to increase our knowledge and increase our ability to help patients with heart failure and dyssynchrony. But that's the basics behind where pacemakers got their start and how they've come to fruition at this point, and also what CRT, or cardiac resynchronization with a 3-lead pacemaker. So you have single lead pacemakers, dual lead pacemakers, and 3-lead pacemakers. And some of the reasons why they're different and what they would be used for. As always, feel free to look up on Google, search for pacemaker optimization, CRT therapy, some of these other things that we briefly discussed. If you find something that you're not quite comfortable with or something that interests you, please mail it to me at john@academyofultrasound.com or email it to me, and I'll be happy to interpret it or take a look at it and see if I can help you understand what you're seeing. That's it for this evening. Again, this is John Sheldon for the Academy of Ultrasound, and I look forward to talking to you on the next lesson. Keep studying.